Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone. Welcome to the Codecast podcast today. My name is Terry Fletcher. So today I'm going to visit a topic that came up in an article I was reading, and then I read a couple of other takeaways that kind of related to the same article. And it was a compliance case study that I saw actually over the internet. I think it was on one of the Medicare sites and also the National Institute of Health. And they were talking about split shared visits. And also payers have weighed in on split shared visits, especially for admission encounters. They are definitely under scrutiny. And remember, split shared means that you have a mid-level provider, an APP, so an advanced practice provider, PA, nurse practitioner, or clinical nurse specialist, and then also a physician who they are pretty much working, I don't want to call it in tandem, but working on the patient's encounter, and they have their own individual aspects of that encounter. And, I was looking at this, and then my good friend Stephanie Allard, who also gives her opinion on this on a blog. It was talking about a large multi-specialty group, and they recently underwent a compliance audit focused on split shared visits in their department for their hospitalists. And I thought that was interesting because hospitalists kind of sometimes think that they're really untouchable because they're employees of the hospital, but they also do use mid-levels. And you always think about a private practice physician using a mid-level or an APP, NPP, whatever you want to call them, and then sharing that patient in the hospital. But when hospitalists actually do it, there was some interesting compliance data revealed on this. And the review revealed that many of the admission encounters that were billed under the physician's NPI were primarily documented by the APP with minimal physician involvement. And the group billing these visits at high-level codes, of course, typically it was the admission code, or what we call the initial hospital 99223, under the physician, assuming that, when you get this quote, review attesting to performance of an exam, a statement that the A&P was the physician and a co-signature, unquote, they thought that met the split shared requirement. And as of 2023, it does not. So when we got the update from the new guidelines for E&M in 2023, split shared visits came under a lot of scrutiny. There, first of all, for Medicare patients, you can only have a split shared in the hospital setting. You can in the facility setting. You cannot have it in the office setting. And the reason is we have incident 2 in the office, and new patient visits do not fall under incident 2. So you can't have a split shared generic compliance, plan in the office for that. And Medicare is very clear on that. Split shares for hospital or facility, incident 2 is for office, and that's just for the established patients. But when we get into split shared visits, especially when it's the admission or the initial encounters, and now just specifically looking at hospitalists, or I would say even specialists or even private practice physicians, you have to look at what does your compliance plan, compliance policy, what is your training telling not only those providers, but those auditors and coders internally what to look for. So let's first look at what went wrong and then the compliance takeaways from what you need to make sure you do there. And again, I want to shout out my good friend Stephanie Allard. Sometimes when I'm looking at things, it's really funny. All of a sudden I'll see her blog, I'll see someone else's blog, and I always want to give them a shout out because even though I blog myself, you can go to my website under articles. It's nice to get everyone's input that you respect in the industry. But what it used to be, let me kind of preface that. So before 2023, we used to have actually it was before 2021, we used to have a guideline with Medicare. It says the doctor just had a countersign and says, I agree, and show some kind of involvement to be able to get the hospital visit billed under their provider as a split shared, provider number. But that isn't the case anymore. As soon as we got the update to the codes, and Medicare basically did some kind of a CERT audit, I'm sure, which is algorithm based, they saw an uptick in the higher services based on the fact that, all these providers were using their APPs to do most of the work, and they didn't change their policy based on the new rules. So what went wrong? The physician did not personally show that they provided a substantive portion of the encounter as defined in this 2024 also was updated CMS guidelines and also the 2023 AMA guidelines. Remember, you can use time or medical decision making, but if you're using time, you have to differentiate and delineate who did what and how much time for each, and only the person that had the most time, they call it the majority of the time, can bill for that service. If you're using medical decision making, then it has to be the substantive portion of the encounter, again, as defined in the most current, which on this is the 2024 CMS guidelines. So that's what went wrong. It wasn't clear. There was no attestation showing the management decisions made personally by the physician. Again, only the attestation saying, I reviewed and I agree with the APP. That's not enough. You can't just say I reviewed and I agree, because that's nice, but that's more about trying to say that they did everything and I'm saying that's fine. And sometimes those are smart phrases and drop downs that the doctor didn't even see the patient. And then one of the other things is medical necessity. These admissions, these are high level admissions. So they're not based on, they're not evidence based, meaning based on the encounter itself. They were basically just involved in what the APP said and then just agreed with it. And a lot of these encounters really did not involve the physician, not in a way that was documented to the fact that the physician did the substantive work or was involved with more of the time. And we get a lot of providers that say, well, that's why I have a mid-level, so that I don't have to do all this work. They save me time. If I have to do the majority of the work, then why do I even have one? Well, because you need to help with the volume, and that is true. But then they get to bill for that service if they're the ones providing the service. Remember, take away something that is from the hospital visits is something that I heard this phrase years ago, and it's always stuck with me. If they're sick enough to be in the hospital, and they're sick enough to see the physician. And it's not to discount what mid-levels providers bring to the table. It's just, if you want to bill it out as a physician service, which is higher, not at 85% of allowable, it's actually at 100% of allowable, then the doctor needs to see the patient for the substantive amount of that visit. And if they didn't, then it is considered a discounted service from a lower level provider. So one of the takeaways, and I thought this was interesting, as far as a perspective, as of 2024, and you have to be very, very clear, time or a key component like medical decision making must be personally performed and documented by the billing provider. So you have to have those things done by the person who's actually sending out that claim. Simply reviewing and signing, that is not compliant anymore for split shared billing. It hasn't been since 2021. 2023, it was clearly updated, and then 2024 it was even more clearly defined. You have to look at the workflow of your department in the hospital. So, just because there is a facility requirement maybe that all hospitalists see, and I'm air quoting see patients, you have to look at the payer guidelines, CMS guidelines, Medicare guidelines, or legal regulations related to who is allowed to perform an admission, and then on those admissions and those initial hospital visits, what part of that hospital visit has to be substantiated with that documentation showing the involvement of that physician, not just signing off, not just saying I agree with the mid-level. And so what you can really do is, first of all, you need a point person, and it should be both a provider and an auditor internally, or even if you have a coder, somebody who can review split shared visit documentation, policies, and templates. Look at what your expectation is of your provider, what the payer policies are, and what the AMA CPT says about it. Conduct internal and external spot checks of hospital E&M claims involving shared visits. Do they have the FS modifier? So do they, identify that was a split share visit? The facility has to, so if you don't have your modifier on there, you're going to have a problem. And then really start those internal conversations focused on compliance and clinical workflow. Many times these things can just be changed, updated, and you can comply with what the rules say if you just update your workflow policies internally and make sure that everyone's on the same page by understanding the published guidance. So remember, these aren't my rules. These are the rules that have been put out so we don't have fraud, waste, and abuse for those higher levels of service that are unsubstantiated. And with who we have as the HHS Secretary in Kennedy, and then also with Dr. Oz, Hemet Oz, and the Medicare Administrator, they are really weeding out this stuff, and they are going to increase reviews, audits, ADRs, additional documentation requests to see who actually is providing the services, who actually can bill for these services. And it has to match the time that you have in the hospital, has to match what you actually say in the documentation. So documentation also has to be substantiated by, were you really there all that time? Sometimes I'll see somebody document something. I'm like, there's not enough hours in the day. You could not possibly have done this. And so those things are important as well. So that's really what I wanted to focus on today, just really looking again at the split shared visit, especially since we had an update last year. And for those of you out there that deal with this on a regular basis, go back to basics, go back to your CPT book. Hopefully you still have 2023. Read what it says in there prior to the split shared underneath E&M service direction. Then read what it says in there in 2024, the updates that we got this year. Then pull it up for CMS and read their published guidance on that. And you also might want to pull up United Healthcare. They have some insight as well as far as their payer policies. And make sure you keep these in one spot and show the overlap, show what each payer wants to see as far as the documentation requirements. And then if you've received any of those additional documentation requests, we call them ADRs, or if you've received a review like the one I just mentioned that happened for that multi-specialty group or the hospital group, make sure that you are educating them on a regular basis, updating them on a regular basis. I can't tell you how many times I've seen people that have the 2021 new guidelines for E&M that, we're now 4 years out, and they never updated them for 2023. They never updated them for 2024. And we even got some updates for 2025 and nobody got updated. They said, oh no, we already gave them the new ones when they came out 4 years ago. I'm just like, oh my gosh. So make sure that you are getting updated. It's really up to you to do your due diligence and know what those subtle changes are. But there are some big ones. So it's always important to keep up on everything, because you're going to be held to that standard when the payers come back, and they're a pay and chase where they will come after you once they pay you. Just because you get paid doesn't make it accurate. They'll come back and say, well, let's take a look again because we've seen a trend, or our algorithm says you're overutilizing, or we're seeing something that is triggering that review. All right, everyone. Well, I hope you are having a good July and you're not getting too hot. We're actually in a little bit of a cooling trend here in Southern California. We are in the high 80s. So that is definitely better than last week where we were hitting the high 90s and even into 100. So it's much more pleasant here this week. So hopefully you're having the same response. Hopefully everyone's having a great week. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.